I'm going to limit my talk today about how chemotherapeutics might affect skeletal muscle and some of the protective effects of exercise. And so my talk's going to have three sections. I'll first start with talking about some of the muscle maladaptations with chemotherapy, and then talk about the protective effects of muscle contraction, and finish with some clinical data about practical exercise programs, possibly for patients. So in cancer, cancer and its treatment can often cause muscle, it can also cause physical dysfunction and disability in patients. And a lot of that effect is thought to be due, at least in part, to its effects on skeletal muscle. And there are a range of different factors associated with cancer and its clinical syndrome that can affect this. The one that I'll be talking about today, obviously, is treatment-related factors. And I've had a really good introduction from Ashley's presentation on this, so I won't belabor this. But we're focusing on chemotherapy. And although there's been a lot of advances in cancer therapy in the last decade or two, the thrust of most cancer treatment in most cancers is going to remain to be chemotherapy, at least for the foreseeable future. And unlike some of those targeted therapies, chemotherapy is something that's rather systemic. And because of that, it can affect a lot of other tissues and organ systems, and in particular muscle, to cause muscle weakness, which Ashley spoke about, and also muscle atrophy, which I'll focus on throughout my talk. And I'm going to also talk about breast cancer patients. So I just wanted to highlight some of the treatment therapeutics that we're seeing in these patients. Ashley talked about one of them, doxorubicin, but another one is the taxane group of chemotherapeutics, which are microtubule stabilizing agents that inhibit cell division. Not going to belabor the doxorubicin, but because it's already been spoken about, but a fair amount of our patients, just under half of these patients, are receiving doxorubicin, and I'll be using that in some of the in vitro stuff that we're talking to talk about. So the question of whether or not these agents affect muscle is probably most directly addressed by the preclinical work, which has looked at administering these agents to animals and seeing if they cause muscle changes. And this is some work from a group from Montreal that did this rather nicely by giving multiple cycles of doxorubicin as well as dexamethasone, which is used clinically in patients over a period of time, and then looking at these animals afterwards. And what you can see is you can see atrophy across a range of different fiber types in these animals. And this is also seen, it's not just the dexamethasone, as Ashley showed. You can see this with just mono treatment with doxorubicin as well. And it's not just those more well-known myotoxic agents that have this effect. You can see this with taxane treatment as well. And this is a study that treated animals with docetaxel, and you can see atrophy in these animals. And in particular, you see this in the soleus muscle, which has a fiber type admixture very similar to human skeletal muscle. And so more recently, you've been seeing this actually and seeing some of these work from preclinical models being translated into humans. This is a slide from a figure from our paper a couple of years ago where we looked at cancer patients, and these are breast cancer patients. This is during adjuvant chemotherapy, so after the tumor has been resected. So it's primarily chemotherapy effects that we're looking at here. And we see lower muscle atrophy, or we see lower muscle size, fiber size compared to age-matched controls. And I should point out that this is about on the order of about 20%. And that same year that we published this work, another paper was published by a group in Europe. This is an exercise study, and I'll hold off on talking about that. And what I wanted to focus on here is the usual care control group in this study. And what you could see, this is a 16-week study of breast cancer patients receiving adjuvant chemotherapy. Again, tumor's been resected, so we're not seeing effects of the tumor here. And what they saw was about an average reduction in fiber cross-sectional area of around 35%, which is pretty substantial considering this is over a 16-week time period. So the clinical studies have caught up to some of the animal studies to say that these chemotherapeutic agents have these atrophic effects in patients. And I just wanted to point out some of the early work that's been done in culture to show that a lot of these effects are probably due to, or could be due to, effects directly on skeletal muscle. So this is using the C2C12 myotubes, and what you can see is that when you treat these muscle cells in culture with these chemotherapeutics, you see a decrease in protein content that's related to a decrease in myotube diameter as well as myosin content. So you can see these effects recapitulated directly on the skeletal muscle. So that's obviously that can lead to some of these physical functional impairments in these patients, and exercise is often recommended these patients to help mitigate some of the side effects of cancer and chemotherapy. And there's a remaining question as to whether or not and how this exercise treatment might, or how exercise might be modulating treatment-related muscle effects. And I'll just sort of get right to the chase here. This is a follow-up of a slide or the slide I presented a few slides ago, looking at that study in breast cancer patients over 16 weeks. And this study was actually a randomized controlled trial where they randomized patients to either aerobic or resistance training, which was coupled with a short bout of high intensity interval training. And what you can see from this is that either of the exercise interventions was effective at mitigating the atrophy in these patients that they experienced with chemotherapy. And in fact, the resistance training was more effective in the context that it actually led to a little bit of muscle hypertrophy. So exercise is effective. And what it led us to the question is how exactly is exercise mediating these protections? And not really at the point of what Ashley was talking about, more of the subcellular mechanisms, but more, a little bit more macroscopically. Is this due to the to the effects of exercise to activate mechanotransductive signaling pathways, or is it more calcium chemotransductive type effects? And this has implications for informing the type of exercise you want to recommend to patients, whereas you're going to have more mechanotransductive type signaling from a resistance training protocol. You're going to get more calcium chemotransductive kind of signaling from something like a more aerobic exercise training protocol. So we decided to address this in a C2C12 myotube model. And I just wanted to provide a little bit of a background of what we're doing. So this is some data from our lab, and we usually start these studies around day 7. And the reason for that is this is after a rapid phase of growth in these cultured muscle cells. And as you can see in the bottom right, it's also when these muscle cells form striated myofilaments. And so they're also at that time structurally much more similar to in vivo muscle. And when we actually hit these myotubes with electrical field stimulation, you can see them contract, and they also have calcium cycling occurring. And when you then take and treat them with something like tetrodotoxin, which is a sodium channel blocker, you can shut down excitation contraction couplings very similar to what you do in vivo, and you can mitigate both contraction and calcium cycling in these myotubes. So at day 7 and beyond, these myotubes behave much more similarly to in vivo muscle than they do earlier. When you look at day 5 or day 6, these things don't contract in the dish generally in response to electrical stimulation, but by day 7, the large majority of them will be responsive. So we have a good model here of looking in a dish at how exercise might be modulating chemotherapy-induced atrophy. So we take these cells at day 7, treat them for 3 days with doxorubicin. And when we do that, we did some dose titration studies. We did this because this level of doxorubicin treatment for this period of time gives us an atrophy in these myotubes of about 20%, which corresponds with some of our cross-sectional data from our prior studies. And so what we did was we treated these cells with electrical field stimulation for 1 hour each day. We started just after chemotherapy was started. And then we evaluated them 23 hours after the last bout of exercise. And when we did that, you can see that the electrical field stimulation completely mitigates the effects of doxorubicin to cause myotube atrophy. And we wanted to further just clarify whether or not this is functioning very similarly to what would happen in vivo. So in other words, it's the electrical field stimulation causing the similar kind of effects in muscle to cause excitation, contraction, coupling, calcium release, and contraction. So we treated these cells with tetrodotoxin, which you can see from the graph on the right, shuts down both contraction and calcium cycling. And when we did that and we treated these cells for the 1 hour during stimulation with the tetrodotoxin, you can see we inhibited the protective effects of exercise to mitigate doxorubicin-induced atrophy. And so we wanted to go one more step beyond that and say, okay, well, if we obviously can do this when we shut down all contraction and calcium cycling. But what is this due to the mechanotransductive signaling or the calcium chemotransductive signaling? When you use BTS to get at this question. So BTS is a myosin inhibitor, And it shuts down all contraction in the myotubes, but it does not shut down calcium cycling. And when we use BTS, we can see, again, this is only during the 1 hour of stimulation, we can completely prevent the protective effects of exercise. And so just some preliminary conclusions from those studies. Chemotherapy-induced atrophy we believe can be modeled in vitro using these cultured myotubes, and electrical stimulation of these tubes to cause contractions effective at mitigating the atrophic effects, and it's likely through mechanotransductive signaling. And I'd say if you're more interested, I didn't have time to present this, but we did a lot more work drilling down the signal and transduction pathways that might mediate this, as well as looking and showing that just mechanical stretch of these myotubes can also recreate this effect. And you can find that in the paper. But I wanted to finish by talking a little bit about practical exercise programs. And this was sort of the impetus for some of these cultured studies. Although it's very important to show with these types of studies, these are excellent studies to show that exercise is effective at mitigating the effects of chemotherapy, but they're not really very practical for patients in general. It's very hard to get patients to do this. So we wanted to look at something that was a little bit more pragmatic for our patients. And we chose neuromuscular electrical stimulation. I'm not going to go into detail about this because it's been spoken about earlier today, but neuromuscular electrical stim has been shown to mitigate experimentally induced muscle atrophy in patients, as well as in certain clinical conditions such as critical care. And so what we did was a small randomized controlled trial of breast cancer patients to examine whether or not this might be effective at inducing an exercise stimulus in skeletal muscle. So we took a bunch of patients and randomized them to either neuromuscular electrical stim or attention control for 8 weeks, and then looked at muscle fiber size and function and a number of other variables. So I wanted to focus primarily on the morphogenic effects of this intervention. And specifically, what we found was in that short 8-week time period, we saw muscle hypertrophy in those individuals who were randomized to the neuromuscular electrical stim, showing very similar to, so the neuromuscular electrical stim that we used was mimicking resistance type exercise intervention. And what you can see is we can robustly produce atrophy in these patients over that period of time. And it seems to be centered mostly in the fast twitch type 2A fibers. And not only do we have morphogenic effects on the fibers, but we also seem to have some effects on fiber typing or fiber type switching. So in our control group, what we saw was a switch towards a more co-expressing phenotype, where you're seeing switches from 2A to 2X fibers during the 8-week period. And that's been previously documented as in both human and preclinical models. But with the neuromuscular electrical stim, you can see we're actually pushing the fiber type distribution away from the 2AX phenotype down to the 2A. And this is a very common response to exercise interventions that both in animal models and humans. So for those two reasons, we believe that the neuromuscular electrical stim is producing an exercise response in these patients. But unfortunately, we don't see a mitigation of the disabling effects of cancer. So you can see here that these cancer patients all experience muscle weakness during this 8 weeks. And unfortunately, the neuromuscular electrical stim was not sufficient to prevent that. And so I should point out that this might be related to the fact that these patients are experiencing cancer-related fatigue, and we're asking them to do a volitional exercise. So it just might be that they're not trying as hard as they otherwise could. But we do have some single muscle fiber contractile data that also says that there's impairments in muscle fiber function at the single fiber level that isn't corrected with the neuromuscular electrical stim. And the reason why the reason why we think that this is the case is that this exercise, although effective, is relatively low intensity. So what we did with these patients is we gave them the units and instructed them to go home and give us, their best efforts. Unfortunately, when patients do this, and this is some data from another study in orthopedic patients, they tend to use the devices, but at a very low intensity. So you can see that the quad contraction induced by this intervention is somewhere around averaging in the mid to high teen level of MVC. So in this study, it was about 17% of MVC, and that's a very low intensity contraction. And from our in vitro data, we know that there's tremendous importance of mechanical stress and strain for this response. So it might be that this intervention is probably just a little bit too low of intensity, or that we have to dose this intervention to get a little bit of a higher muscle contraction in order to see more benefits in these patients. So I just wanted to wrap up and conclude with the talk today that we have shown that exercise is effective at preventing the deleterious effects of chemotherapy on skeletal muscle and culture, and that this is likely due to the effects of mechanical stress and strain of the contractions. And unfortunately, our home-based neuromuscular stim, although effective at eliciting an exercise response, was not effective at altering the effects of chemotherapy to cause muscle weakness. And like I said, that's likely due to the fact that it's relatively low intensity contractions, and we hope to conduct some clinical trials in the future to maybe expand upon that and test higher doses of that intervention. And I just wanted to say thanks to a lot of people who helped with this work, the most important being the patients that we've had come in and do some of the work, without whom we couldn't do any of this, as well as our funding sources, which I didn't put up here, which is the NIH. And thank you very much.
Super great. Thanks, Michael. Fantastic talk. Questions for Michael? I'll start with one logistical question, Michael. I was curious, in one of your early slides when you showed the effects of adjuvant therapy on the muscle of breast cancer patients, how long post-surgery were those studies? Do you recall?
Well, in ours, the patients were tested, and that was a cross-sectional study, they were tested average of 60 days into chemotherapy.
Okay.
So they typically start chemotherapy about 2 to 3 weeks post. So, I mean, you're looking out quite a distance from surgery. The other ones that I cited, I honestly, off the top of my head, don't know. But typically folks are into chemotherapy about 2 to 3 weeks after surgery.
Thank you.
May I, very short question. How long you stimulated the patient?
So
by
the
NMES?
Yeah, so the patients were doing an hour of stimulation per day, 5 days per week.
1 hour stimulation a day for how many days?
5 days a week for 8 weeks.
Maybe it's not enough to obtain a
Yeah, it's
but it is not far from the usual treatment that is effective in other groups.
Yeah, and and we had very high compliance, I should say. It's much better compliance than you would with a facility-based program. Unfortunately, I can tell you, just working with all of these patients, that I think an hour a day is about all we're going to get out of them to be able to do this kind of stuff. So it's probably going to have to be more intense contractions versus more volume of actual neuromuscular stim.
Anyhow, the pain problem is the main issue. To avoid the pain and have a good contraction is not very easy at all. Thank you.
If I can ask a question, this is Jose Garcia. Thank you, Michael. This is great. I was wondering if you think that these patients could have titrated themselves up to higher intensity, or is there any way to sort of tweak the protocol to make it more effective?
Yeah, thanks, Jose. I totally agree. I think that we can do better and be a little bit more progressive with this. I think it's very difficult in the context of most breast cancer patients, at least. I mean, they're mostly in the 40 to 60 year age range, so they've got families and jobs and everything else to deal with. So we've actually we've been working with some other folks in engineering and computer science to actually instrument these devices with sensors and be able to use a cell phone app to contact these patients so that we could actually do this remotely. And so I think that trying to do those types of things where you can dose the patients directly, but by distance, virtually, I think it's going to be able to help to have a little bit more control on doing exactly what you're saying, which is trying to push these patients to get a little bit more of an intense contraction during the neuromuscular stim. So I totally agree. That's what we have to do, and we're trying to move in that direction.